So I think that Dr. Karnik should get 2 umbrellas. How many think he should get 2 umbrellas, not just 1 umbrella? Not to make a pun, but he didn't miss a beat. I couldn't help it. I don't think I've ever seen anything like that. Somebody who was able to continue talking. I mean, this, I don't know if you heard it in the back, but it was really loud here. So thank you very much, and we apologize. I know that they're having a great time, and it's really an important part of their presentation over there. So you didn't show, you were unflappable, which probably is the reason you're so good at the work you do in Chicago, working with homeless youth. So great work, thank you. So next I want to bring up Ken Minkoff. Where is Ken? Oh. I just went into a panic attack, Ken. I was going to have to. I was going to have to send Megan and the squad after you. Ken has been a leader in co-occurring mental health and substance use disorders for most of my lifetime. Right, Ken? So it's really, we're very proud to welcome Ken Minkoff. He's such a force in the field, so we're very fortunate to have him. Thank you, Ken.
Thanks, Brian. So, hi everybody. I was getting mic'd up because I don't like to stand behind a podium. It feels kind of weird. But I am delighted, to be invited here to talk to all of you about co-occurring mental health and substance use disorders and people with other complex needs. And I was particularly delighted to be invited to do the technical assistance paper, which is about integrated services and systems for people with co-occurring disorders. What's known, what now, and what next, which is. And, just like the previous speaker, I'm not going to go through the paper, which is 20,000 words with over 200 references. But the end point of the paper was that we would, provide recommendations to state leaders and other policymakers for how to address this issue systemically and how to improve services for people and families with co-occurring mental health and substance use issues and other complex needs, using different kinds of policy initiatives and transformational change initiatives and so on. So I would invite you to, go read the paper when it gets up on the website. But, in being at the conference for the last couple of days, I thought, what is it that would be most helpful to focus on? And one of the things, oh, and by the way, unlike the other speakers, I don't have a slide with my email address in big letters. But it is on the bottom of this front slide. I know you can't read it, but it is on the app or something. And if you want to get in touch with me afterwards with questions, because there's a lot to talk about, I'm happy to do that. I have business cards. And I also put many more slides into the presentation than I'm going to go through, because this goes into a lot of stuff. So feel free to get in touch with me afterwards and ask me about anything about this, topic. So what I decided to do is, I was very inspired yesterday listening to the stories of people who were following their own recovery journey. And I began thinking that this whole presentation is about a number of intersecting stories. So first of all, there's a story about how this presentation the paper came to be in the first place that I'll be sharing with you. But the most important part of the story are the people that we're trying to serve, but also the story of all of us in this room who are, behavioral health leaders in the field. I'm assuming all of you guys are leaders in some way, because this is a conference on leadership and program direction. And that, if you think simply about whatever system or organization that you lead, one of the things you're going to think about pretty quickly is that inside the people you serve, there are, and here I was praying that I wouldn't be drumming. Anyway, so inside the people you serve, there are people and families who have both mental health and substance issues and other complex needs. Is that right? Okay. So as leaders, not only do we want to help people who receive services in our system go down a pathway of recovery, we ourselves want to be the very best leaders that we can be. Most of us want to change the world in our systems so that we can achieve not just, create a few special projects or some special programs, but actually transform our systems to be about the people who need us the most. So that's the story that I want this presentation to mostly be about. And I'm going to start a little bit with how I got to do this in the first place. I started out as a community psychiatrist back in the 70s, and starting in the 80s, I began working with mental health and addiction, not knowing hardly anything about addiction. And I first published on an integrated recovery model for people with both mental health and addiction in 1989, 30 years ago next month. In 1991, I published something on designing systems of care for people with co-occurring disorders. And in the mid-90s, SAMHSA asked me to chair a panel on designing systems of care for people with co-occurring mental health and substance disorders. And we published one of those cool 150-page reports that probably no one ever read, and you can't even find it anymore, and it came out in 1998. And we recommended all of these things for systems to do to design themselves around providing integrated helpfulness to people with multiple mental health and substance issues. So over the intervening 20 years, I've been working in the last almost 20 years with my partner, Dr. Chris Klein, who hired me when she was the medical director for behavioral health services in New Mexico. And then 10 years ago, we got married, and here we are. We're working all over the place, all over the world, working on integrated services and systems for people not only with mental health and substance use disorders, but with all kinds of complex needs. John was talking about TBI and so forth. We did a project in Iowa around integrated services for people with mental health, substance, intellectual disability, and brain injury, what Iowa called multi-occurring services. And we're working on that for several years. So there's lots of that out there. So, when I was asked to do this, I said, okay, so literally over the past several decades, what's been going on? What level of progress has been made? What do we know? Is there anything new? And most importantly, what are we going to do about it? And one of the things that you guys may have be familiar with is certainly, visible in the United States if you step back and think about it. In the early part of the 21st century, in the first decade, there was a lot of stuff going on around integrating services and systems for people with mental health and substance use disorders. SAMHSA had funded a co-occurring center of excellence. There were COSIG grants that were out in 19 states over a period of time, where there are infrastructure development grants for improving integrated services across a whole state. There's lots of stuff going on, things being published, stuff being done. And suddenly, in the early part of this decade, it's just stopped. And most of you probably didn't notice. It's just there's plenty of noise. I noticed because this is something I think about. What happened? And I began to get the sense that there are several reasons why things stopped. First of all, a lot of people were feeling like, oh, we fixed that. We merged our mental health and substance department at the state. Now we're calling ourselves the Department of Behavioral Health, so we're integrated. And in case you guys hadn't noticed, just rearranging the boxes on the org chart doesn't produce integrated care out on the streets. Okay? Okay, so now I know we're talking the same language here, okay? In addition, there was that been there, done that. Oh, I worked on that for 2 years. We made some progress. Now we're done, right? And then the next latest, greatest shiny object that came along, we all decided that we were going to focus on integrating with primary health, which was super important. But then we just called it PHBHI, Primary Health Behavioral Health Integration, which gave everybody the idea that the behavioral health part was already solved. No worries. All we have to do is figure out how to do this with primary health. And as many of you know, we immediately began to siloize our relationships with primary health. We work on depression over here and expert over there, and everything started falling apart. And so there's a time period when it all stopped. And then the last year or two, things, people have gotten interested again. And unfortunately, one of the drivers of interest has been the opioid use epidemic, the opioid overdose epidemic, and people recognizing that people with opioid use difficulties of a variety of kinds have co-occurring mental health issues, that people with serious mental illness have higher prevalence of opioid use disorders. And we didn't fix it. And secondly, we've come to realize how much this is an issue when we look at important issues like criminal justice diversion or crisis service system development. As Margie Balfour was saying yesterday, if you're drunk and suicidal, people start playing pinball with you about how they're going to help you. So this has started to come back to our awareness. And that's why I think this is so timely. The other thing about this issue is that when you really start thinking about mental health and substance issues and other complex needs, it gives you as a leader a framework not only for addressing that particular issue, but it gives you an entry into literally thinking about how to change the world in your own system. Because the driver of what we're doing as leaders is not the problems, the mental health and substance or the TBI or the homelessness or whatever, it's the people. And we know we run systems. And the systems have not enough money, but they also have lots of money. And they have big and complicated bureaucratic structures, and that money is being spent all the time. And the question we have to ask ourselves is how well matched are the systems we're running to the people who actually need the help of those systems, particularly those who most need the help of those systems. And as you know, people are constantly coming to the door of our system, whatever it is that you operate, with all kinds of desperation and complexity. And they encounter systems and structures and rules and paperwork and bureaucracies and requirements that make it feel like the job of getting help when you're desperate and complicated is going to be really, really hard. So what we need to be thinking about is not, again, how we fund a special project for the co-occurrings, but how do we organize everything we do in our system. And by everything, I literally mean everything. Every process in the system, every partnership in the system, every program in the system, every policy, procedure, practice, every piece of paperwork, every person providing help, and every penny that we have to be about the needs and hopes of the people that we're serving and the values that brought us into this in the first place. Now, one of the things that would be super helpful is if somebody gave me that little bugger thing. Here it is. Yay! Okay. So when we starting those conversations, one of the things to think about is you want to design your system around the people who need you the most. So I call this the complexity challenge, and people with co-occurring mental health and substance issues are one example of the complexity challenge. And whatever complexities you start with, as you've learned already today, you immediately wind up with others. So let's define co-occurring for a minute. Any person of any age with any combination of any mental health issue and any substance issue, okay, whether including trauma, including nicotine dependence, including gambling, whether or not they've already been diagnosed. In the world of working with kids, It's important to remember there are co-occurring families where one person has one kind of problem, like a child with an emotional disturbance, intellectual disability, cognitive disability of another kind, and the family member or caregiver has a substance use issue, so the family system needs an integrated approach. Now, the first thing we think about is these folks are everywhere in our system. In addition, whatever two issues you start with, you immediately find out there are others. As we were hearing, these folks are more likely to have every other possible thing wrong. They're more likely to get in, have criminal justice issues, health issues, cognitive issues, housing issues, parenting issues, etc. These are folks who are characterized by complexity. The next thing we realize, that the more complex you are, the worse you're likely to be doing. So these are the folks who are likely to be having the poorest outcomes and the highest costs in our scarce resource system. John Corrigan's presentation showed one aspect of that. The presentation on homeless youth shows another aspect of that. You don't have to go far to learn this. We keep learning it over and over again. But the implications are important. So these are the folks who are most likely to relapse and be rehospitalized. They're more likely to be labeled treatment resistant and non-compliant. They're more likely to engage in self-destructive, suicidal, aggressive, or violent behavior, be victims of trauma, perpetrators of trauma, or both, be in trouble in other systems, cost a lot of money, and most tragically, these are folks who are most likely to die. And one of the ways that we got started in this, when I got hired by my partner in New Mexico, was that she was a junior baby newbie medical director, and her boss, the commissioner, she said, Dr. Klein, this is going to be the easiest job that you've ever had. And Chris said, well, I wasn't looking for an easy job. And she said, well, here's the deal. All you have to do is help make it better, and it can't possibly get any worse. And so they, like many of you, were having class action lawsuits and people dying. And she said, so the first thing I want you to do is to figure out what it's like for the people in our system having met us as a state system. And she said, okay, great. Where do you want me to do that? She said, I want you to represent us on the State Mortality Review Committee, which is a very interesting framework. The way we're going to learn what it's like for people to meet us is to go sit and look at the stories of all the people who died. And so, they immediately started thinking, how do we do this in such a way that we're looking at not who died and who should we blame so we don't get sued, but how do we figure out how to improve what we're doing so fewer people die? So the first thing they figured out is that people who had co-occurring mental health and substance issues died earlier and at higher rates than people with single problems of either type, who died earlier and at higher rates than people in the general population. And this was in the late 90s, and they discovered what we all know now, is that mostly they died of all kinds of things: suicide, homicide, violence, accidents, mostly of routine medical conditions. And not because they had no access to care, although sometimes that was true, but mostly because they weren't participating in doing the things that would have kept them alive longer. And then they noticed a pattern, which was that a lot of the people who they were studying in their trend analysis were dying of medical conditions within 4 to 6 weeks of having knocked on a behavioral health door. And they couldn't figure that out. And they looked at the charts and they still couldn't figure it out. So they decided to call the family members and loved ones of the people who died. What happened when your person knocked on our door and that person had complexity, and then 4 to 6 weeks later they died? And the message they heard in multiple languages was, when our person knocked on your door with co-occurring complex needs, they came back feeling more hopeless than before they went. And you kind of know how this happens, because when people are the system is designed so that people with complexity are a misfit, everybody feels a little bit like, I'm happy to try to help you, but I have no idea what to do. And then the person who's out there living on the edge, being desperate, goes away feeling like, oh my God, hope was keeping me going. I finally wound up talking to somebody who could maybe help me, and they acted like there wasn't much to do. So now I have a little bit less hope. I make fewer good decisions, and I'm close enough to the edge that might kill me in 4 to 6 weeks. Okay, so you guys know how this goes. So this launched a whole effort. And she actually was one of the 4 people in the United States who read that 1998 report except she didn't read the whole report. She only read the opening paragraphs, and it said something about how to design systems for people who need it. And so then she hired me, and then we began doing the work. But the key issue here is that if our job as system leaders is to design systems for the people who need us, then naturally we would be thinking at every single level of our system that the people who have co-occurring mental health and substance issues and other complex needs would clearly be prioritized for system attention. And what we experience is the opposite. That still, in most systems, that these folks wind up being experienced as misfits in most places. At the system level, things are designed and regulated as if people had one problem only or only one problem at a time. Programs are similarly designed. People are trained to think of themselves as only doing one thing. And not only are these folks experienced as misfits, we wind up experiencing them negatively. They don't fit neatly into our designed boxes. They don't follow all our instructions the way we would love them to follow them. They don't keep all the appointments we would love to schedule. They stir up feelings in us. And the feelings range from helplessness and despair to frustration and rage, and they become the antisocial, manipulative, borderline, med-seeking, non-compliant sociopaths. And, people are introduced to them by their colleagues before they've ever met them. So one of the starting places for thinking about how to design a system, and you look at the evidence and say, here's one thing that you know. If people never get connected to help, they're unlikely to get better. If people wind up getting kicked out because they don't behave well, that's not going to be a good idea. So how do we design our system so the people with the greatest need are welcomed as priority to care wherever and whenever in our entire system they show up? The second challenge is that we need to be in the hope business. We talked about recovery and hope this whole conference. But Devora from the World Health Association, yesterday she talked about World Health Organization. She talked yesterday about, business practice and disruptive innovation, blah, blah, blah. In organizations and systems, there's a little thing that says every organization is perfectly designed to achieve the results that it gets. So you have to think about how your organization is lined up to produce the results you want. And so one of the things that I say is if, the more challenged people are, the more important it is that we inspire hope when we see them. So we need to be in the hope business. And so we have to ask ourselves if our organization is designed to produce the product of hope increase every contact, or are we more focused on producing billable units? And thinking about how to design organizational practices to produce the things that actually work. Now, within this framework of thinking transformatively, the other driver for doing this with folks with mental health and substance issues and other complex needs is not only are these folks doing poorly, there's lots of them. So co-occurring or complexity is an expectation, not an exception, pretty much everywhere we look. And there's tons of data about that, okay? And you can easily look at it, at least anecdotally, even though it's probably not reflected accurately in your data systems. Okay? The thing about this is not that we don't know this. The striking thing is how much we've organized our systems at every level with limited resources as if this wasn't true. So we design our systems as if people had one problem, and then all these folks with multiple problems have a hard time and don't do well. So we need to flip that around. If, in fact, these folks are doing worse, and there's lots of them, then we need to think differently. We're never going to get where we need to go simply by trying to fund special programs or hire special people to work with co-occurring like this is some kind of weird special population. We need to build the capacity to welcome the needs, inspire the hopes, and provide integrated helpfulness to people with co-occurring mental health and substance issues and other complex needs inside every single thing we do. So when I talk about a system, you know this, most of you run pretty big systems. And so thinking about how to create change in big systems is daunting, But one of the things we're learning more and more about, although we still have a lot to learn when we look at this, is how do you implement things, not just in a single program, but how do you implement things systemically? One of the learning areas in the United States has come from the VA, which has established a set of mental health standards for the entire system, and they actually have a structure for implementing them in each and every region and each and every facility, so that there's a process of moving through all the systems and within systems, within systems, within systems. And so transforming means you're thinking about how to move your entire system, not just a few places. Because you can spend 5 years doing a demonstration project and the rest of the system sits still, and what happened? So in the framework that we've been learning about these years, there's actually a framework for saying, well, what does it mean to say, if what we're saying is that basically every program has to be a co-occurring program in your entire system. Why is that? Well, because pretty much every program is going to have co-occurring people or families in it. And so, I ask folks who run programs, and I say, so are you guys a co-occurring program? Sometimes they go, yeah. And sometimes they go, I know you want me to say yes, but... And that hesitation means you're sitting there, and you're thinking, oh, the system is hiring me and funding me to do a certain job, and they've sent me the wrong clients. Okay? So in this framework of transformation, you're saying, how do we have all of the programs in our system become co-occurring programs, become welcoming and hopeful, become strength-based and recovery or resiliency-oriented, become trauma-informed, and be what we call co-occurring or complexity-capable. And there's a whole language and tools and work that people are doing. I don't know if Heather is still here. Hi! Okay, so Heather and and us, and there's a whole universe of the doing of this that's been out there. It's not as well studied and spread out as it could be, but there's been an awful lot of work. And part of Heather's role, I think, and correct me if I'm misspeaking, but in addition to the coordinating mental health technology transfer center, there's a center point for starting to advance co-occurring development efforts along the lines of what I'm talking about. Not only every program, every person providing help has to be in the learning how to be competent, to be helpful to people with complicated needs. Okay, and this is not about everybody getting multiple licenses and degrees. This is whether you have 6 licenses or no license at all. You're a cool peer support specialist. You're the residential staff in the substance program when everybody's trading meds and being really weird. Okay, so everybody can be helped to understand how to do this with the people in front of them. So this is a big vision to get there, and we have a whole bunch of tools for different types of populations. There's another set of tools, DD-CAT, DD-MUT. We talk about the tools and the work and the stuff that's been published and studied, which is still limited in the review paper. But the issue is, like most things, we know an awful lot about how to do this, but we just don't do it. So people are constantly like, well, how do you help people with co-occurring needs? Well, actually, there's been a substantial amount of work that tells us how to be helpful. And the thing that we've learned over the years, is that the more that you're dealing with folks who are complicated, the more helpful it is to make the intervention simple. It's just like what we were just hearing about for the homeless youth. And so if you're wanting to transform your system, think about the simple foundational things that you want everyone to do, so they do more of the stuff that works and less of the stuff that actually doesn't work, where you're spending money to produce bad outcomes and spending more money to work around your own service system. So what we've learned, and the way you do this is that you actually start to build on what we're learning, this is a new area as well, about transformation or implementation science, which is not just implementing a single practice, but using the language of a quality improvement partnership across your whole system to do data-driven improvement at every level, where everybody is welcome to be participating, where you create a structure for empowered change involving frontline people and service recipients at all levels, representing all services, to actually move things forward within your organized infrastructure. You focus on emphasizing how do we create change in our bureaucracy that sustains the right practice, get rid of the stuff that gets in the way. And how do we do this within what I call the serenity prayer of change? Okay, don't sit there thinking, oh, I've got to change somebody else. But what do I do inside my world? The serenity to accept the things you cannot change, which is everybody else. The courage to change the things you can, your own work, your own program, your own system, your own span of control, and the wisdom to know the difference. Now, I'm just going to illustrate what we've learned over the years is, and it was summarized in the paper. What is it that's helpful? And there are some 6 very basic things that can organize things that are fairly simple. So one of them is welcoming. Co-occurring is an expectation, so let's welcome people with complexity as a priority in everything we do. And this is basic customer service. This is, it's not just being nice, it's technology. Hi there, you're one of those folks who has lots of complicated needs. You're hearing voices. It smells like you had a couple of drinks coming in here today. You have medical issues. You're in trouble with the law. You got kicked out of your housing and your family doesn't like you. You're the kind of person we most need to be engaging because you're likely to be having the hardest time. Thank you for coming. You're in the right place. We're glad you're here, and so on. And there's nothing about the speech that's rocket science. The question is, how organized in your system by policy, procedure, and practice does everybody know when people who are complicated show up, that's what they're supposed to say? And that's where we started in New Mexico. And we started with, let's not trash talk about people because they have complexity. Let's not kick people out of care because they have symptoms we don't like. And then let's really get good at identifying, welcoming the opportunity to identify people with co-occurring needs and improve what's in our data. I mean, if you look at most of your data systems, you know that you're undercounting prevalence of co-occurringness. And if we're not counting you as a system, it's because we're organized as if you didn't count. In New Mexico, when we started, the data for the whole state on co-occurring was 8%. The reality was 60 to 70%. Over a period of 3 years, it worked to get itself up to 32%. And in that time period, the death rate was cut in half. Just by welcoming, engaging, identifying, and let's find some next steps to work with people. What are we welcoming people into? Well, the research tells us that people with co-occurring and complex needs don't get fixed in a few weeks. They need to be engaged in relationships that are partnerships, that are hopeful and strength-based and integrated. So we build hope by emphasizing the importance of creating inspired visions for folks, because that drives them to change. Every good program that you will read about is hopeful. Integrated. We're partners with you to help you with all your issues. We're not bouncing you all over the place. We're strength-based, not as a sprinkling of nice strengths while we focus on your problems, but everything we do is strength-based because strength-based stuff helps people with complex needs make progress. There's no such thing as a chronic relapser, only people who are recurrently successful. Do we build this stuff into the way our services are designed? So one thing I always ask audiences, are you wanting to be welcoming and hopeful? Yes. Does your system give you tools to meet clients with? Yes. When you open up those tools, do they scream welcoming and hope at you, or do they scream mind-numbing data junk? And everybody answers the question the way you know it is. And I say, why is that? And they'll say, well, they make us. Medicaid makes us. This makes us. Is there some rule that says we can't put welcoming and hope as a centerpiece of our own paperwork? And why don't we? Here's the next print. And by the way, it takes time. The research shows that for people with complicated needs, in like integrated dual disorder treatment, it takes 3 to 4 years for half the people to get sober. During that time, even the ones that are not getting sober generally are making progress and having better result. So we need to be patient, because a lot of the way we design things creates expectation that people are going to stop using within a period of weeks or months. And then we start feeling like they're failing, and we try to fix them quicker, and it costs more and does worse. What else? All people with co-occurring needs in our system are not the same. And it seems obvious. There's people with high severity mental health and higher severity addiction and lower severity. So different programs have different jobs. Everybody's got to help each other. But the thing that's most important is if somebody comes to you and says, so, I'm looking for a co-occurring program. They're asking the question as if all people went into the co-occurring program, when the diversity of people with complexity is at least as much as the diversity of people with any single issue. All the issues are primary. So one of the things we've learned is that the best practice for treating people with two disorders, this is a big duh, but whatever the best practice is for helping anybody with a substance use disorder is going to be a good idea for helping somebody with a substance use disorder who also has a mental illness. It's helpful to integrate it because the person has both, so they need to figure out how to find the right next steps for each issue at the same time, and that's what we're helping them to do. But the interventions are what we know are the interventions. So for any, one of the things we're learning, for example, is that we need to keep people on the best psychotropic medication for their mental illness when they have a co-occurring substance use disorder. And clozapine turns out to be the one antipsychotic that's not only better, but helps people reduce their substance use, at least in a wide range of studies. And we need to make sure that people with serious mental illness have full access to medication-assisted treatment. So that one of the things you think about is, do all of the prescribers in our mental health system understand that part of their job is prescribing medication for people with substance use disorders, including alcohol use disorders? Okay, and there are medication interventions and psychosocial interventions, and there are things for diseases, and there are things for housing issues and so forth that are all kind of on the slide. And you help everybody find their best next step. What's the next thing? Well, one of the things we also know is the whole concept that's been reasonably well researched of stage-matched interventions and stage-matched outcomes. And we all know about stages of change or stages of treatment, but the key element is that if you ask what stage of change is the client in, the correct answer is for which issue. So stage matching needs to be for each issue. And you start to think, have we programmed the way people think about service delivery so they understand how to stage match for each issue with people with complex needs? Start with the thing that's most important for the person, help them connect slowly over time where they are around other issues, and be able to track their progress through the stages, not just measure outcome when they achieve maintenance. And then finally, what do we do for people? One of the things we're learning is that the way we help people with all of these needs is not just to tell them what to do and give them pills. We actually have to teach people the skills they need to succeed for any issue, whether it's staying out of jail or maintaining housing or getting a job or managing a chronic mental illness or managing a chronic substance use issue. So we have to help people learn, and we have to build the learning into the work that we do. And increasingly, we're learning to focus on skills and skills training and, building small steps of skill practice into our work with big rounds of applause for small steps of progress. And there's some cool skill manuals. I brought one along. I forgot to bring it up. But, it was developed 20 years ago. And there's still, to me, nothing that's come along lately that's any better. People stopped working on these things quite a while ago. It's from Liberman's group, Bob Liberman in Los Angeles. And they developed a substance abuse management module. They published a book called Overcoming Addiction, Skills Training for People with Schizophrenia. And, it has chapters, like 10 pages on refusing drugs offered by a dealer. So when you see the dealer, walk fast. Don't smile. Don't make eye contact. Don't start a conversation. If the dealer offers you drugs, don't say yes. Say these other things and things like that. And it goes on. There's pages and role plays and all this stuff. And it's really simple. And what it reminds us of is that we make this stuff really complicated for the people who are out there trying to help folks, when in fact, as system leaders, we need to help everybody make things much easier. So moving forward, if you want to be thinking about how to transform your system, okay, these are kind of the recommendations that are at the end of the paper, and there's a whole lot more detail. But the first thing to think about is, have we designed our system at least to have a vision that every program and every person providing help is going to be in the co-occurring business? Have we said out loud that we want every one of our programs to be co-occurring capable within the funding, within the resources, within the job that it actually has, for the people that it actually serves? Have we created a pathway to get there using the available tools to do a self-assessment and have a quality improvement approach so that all of your whole system starts moving forward a step at a time? Have we started improving our ability to collect data on how many co-occurring people we're actually serving inside each of our data sets? Have we started looking at our own policies and say, are they written as if the next person coming in is likely to have co-occurring, and within this policy, we want you to help them? Are our funding instructions written so that if you're treating mental health, you also should be delivering integrated substance help, and conversely? Have we developed a workforce expectation that everybody learns how to work with co-occurring people from the beginning? Are our crisis services set up so that nobody can be turned away because they show up actively using substances, and that we stop using the idea that you have to demonstrate that your alcohol level is low enough to drive a car before somebody will talk to you? Because that's all the alcohol level means. And yet all over the world, people say, we can't talk to you until your alcohol level is below the legal limit of intoxication, which makes no sense. So there are things that you guys can do, and as transformative leaders, to get to the point where your entire system is organized around the needs of and hopes of the people who need you the most, because they have mental health and substance issues and other complexity. So that wherever anyone shows up, any family shows up, they encounter welcoming, empathic, hopeful relationships that are continuing integrated recovery and support partnerships, where they help people address all of their primary issues and provide adequately supported, adequately rewarded, strength-based, skill-based, stage-matched, community-based learning for each issue, so they all make step-by-step progress toward the goal of having a happy, hopeful, meaningful life that everyone is capable of achieving and deserves to get. Thank you very much.